You're listening to the second season of Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carel Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carel Wysham. Welcome to the second season of Medscape's In Discussion series on type 2 diabetes. Today we'll be discussing insights into the importance of weight management for treatment options in diabetes. First, let me introduce my guest, Dr. Carel Roux. Dr. Roux is a professor of experimental pathology at the University College Dublin School of Medicine. Welcome to In Discussion.
Thank you very much.
I always like to start by asking my guests some icebreaker questions. I've followed your career for a long time. You've established a world reputation in obesity field. What motivated you to enter this field?
It was a really interesting question, in 2000, and I actually did not think there would be an answer. I thought that obesity would be one of those diseases like a balloon. If you squeeze it on one side, it'll just pop out on another side because there's so much redundancy in the system. So I thought it was an important question to address, and I was fortunate enough, to have great mentors and great opportunities. And as they say, the rest is history.
Well, thank you for that. So let's get into our discussion. As you know, the new ADA and ESD recommendations for the treatment of patients with type 2 diabetes have elevated the management of weight as an important focus, almost a co-primary endpoint to the importance of treating hyperglycemia. I'd really like your insight as to how and why you think that has developed now compared to the past, couple 3 decades where we've known weight was the underlying pathophysiology of diabetes.
I want to commend the ADA and EASD. Sometimes an idea has just the right timing. And I think this is what happens when we talked about treating the disease of diabetes by also treating the disease of obesity. And we are now developing the evidence that it doesn't matter what modality you use, whether or not you use a nutritional therapy, a pharmacotherapy, or even a surgical therapy, that we can disrupt diabetes by intentional weight loss of more than 10 or 15%. I think the evidence, therefore, was just overwhelming. And, people are smart, and the ADA, EASD are pretty smart people. And they worked out that this is a great opportunity now that we have these tools to apply to our clinical practice. And that's why I think it happened. And it's a fantastic opportunity for us as clinicians, but really it's going to make a massive difference to our patients who are living with type 2 diabetes.
Yeah, I like to think of this almost as important as back in the early 80s when I started my practice and we started understanding the importance of good glycemic control. And at the same time, we're having better and better tools to allow us to do so. So I think that the importance and the timing couldn't be better. And I agree with you on that. So let's talk a little bit about the role of obesity in the pathophysiology of not only the complications of diabetes, but also the very frequent comorbidities that coexist in our patients with diabetes. What evidence do we have that weight loss will improve these?
I think when we go back, we have to learn from type 2 diabetes. And, maybe 20, 25 years ago, people did not take type 2 diabetes seriously. We did not think that it was a real disease. We thought it was a sort of a lifestyle choice. But it was the UKPDS and other similar studies that changed our minds, that showed that this is a disease that causes complications, serious complications, macrovascular and microvascular complications, but that when we intervene, we can really make a difference. And I think, fast forward 20, 30 years, and we are repeating that now with obesity, where we, for the first time, are understanding that obesity is not a choice. It is a disease in its own right. And when left untreated, it could have serious complications. And one of the most common complications is type 2 diabetes, which then in its own right spins out of control and gets amplified by the disease of obesity at the same time. But I think the turning point, similar to type 2 diabetes, was when we actually developed tools, treatment tools that we could scale and where we could show that we can have 10-20% weight loss in people with type 2 diabetes and understand the benefits of that, not only from a weight loss point of view, but also from a health gain point of view. So in summary, we understand obesity as a disease, we understand that we can treat it, and when we do treat obesity effectively, we can prevent the complications such as type 2 diabetes, but we can also improve the complications such as type 2 diabetes and the microvascular side effects of that.
Yeah, I think it's also quite interesting to be thinking about how many other conditions that people with type 2 diabetes have besides the hyperglycemia and the intended complications of diabetes per se.
Carel, I just want to come in on that because, you're so right. When I treat my patients in the diabetes clinic and they have 10-15% weight loss, I ask them, what's the most important thing to you? And yes, of course, I'm delighted with the hemoglobin A1C that's improved or the cardiovascular risk that's improved. But so many patients with type 2 diabetes say, you know what? The most important thing is that I can cut my toenails or I can get on an airplane without an extension seatbelt. These so-called non-scalable victories, that's what drives the quality of life of our patients. And, I cannot agree with you more that we need to think of this in a holistic way to help our patients with type 2 diabetes, not only from a glycemic point of view, but also these important aspects that drive quality of life.
Yes. Yeah, I love that term, holistic view of taking care of our patients. And I think your point of the non-medical aspects of treating obesity is something that we have not spent enough time on, and I really appreciate you bringing that up. So can we go back to some of the other comorbidities that, medical comorbidities that our patients are facing? Can we discuss what you would recommend in terms of weight loss and the amount of weight loss necessary to improve some of these, such as cardiovascular disease, a non-alcoholic fatty liver disease, other of the complications of diabetes?
When we think about patients, with type 2 diabetes and obesity, we really think of these complications, in a mechanical way, in a metabolic way, but also mental and even monetary, so those are the 4 M's that we are talking about. And depending on the complication of the specific patients, we may have to streamline how much weight a patient needs to lose. So it's not necessarily the starting weight that's important. It's the amount of weight loss that we need to disrupt these complications. Now, the glycemic control is the most sensitive of all the complications. So we know only 5% weight loss can be incredibly powerful in preventing people developing type 2 diabetes. So we saw that with the diabetes prevention program, the Finnish diabetes prevention study. But if you have type 2 diabetes, then it appears that we need about 15% weight loss to put the diabetes in remission or really to disrupt it. When we think about cardiovascular complications, the look-ahead study would suggest that those patients that had more than 10% weight loss, they also had a cardiovascular benefit. So I think the industry standard when it comes to weight loss is changing. In the past, we talked about 5% as a target, but I don't think 5% is good enough anymore. I think we really need double-digit weight loss. And when we are thinking about double-digit weight loss, it appears that 15% is better than 10%, and it may even be that 20% is better than 15%. But I would aim in my patients with type 2 diabetes that we achieve at least 10% weight loss when we set that as a target.
So obviously, diet, exercise, behavior modification has to be a part of the plan, but we do have some very powerful medications that now can help our patients with diabetes, and for that matter, patients without diabetes, lose weight. I'd like to start with the GLP-1 receptor agonists. As we know, the most powerful medications we've had up until the last couple of years. But it strikes me that they're not all the same. In your comments about why you think semaglutide seems to have so much greater benefit compared to the other agents in that class.
I think it's correct what you say, and I would agree with you that lifestyle treatments remain the cornerstone of everything that we do. But we also need to appreciate that nutritional therapies, exercise therapies are similar to all our other therapies, that we find responders and non-responders. And we find that about 2 in every 10 people will respond very well to a nutritional therapy. But the 8 out of 10 people that don't respond, it's not because they've done anything wrong or they're not listening. They just don't have a biological response. So I think this idea that we start, but if it works, we continue. If it doesn't work, we escalate. And what you're saying about the pharmacotherapies, especially the GLP-1s now for people with type 2 diabetes, that's been very powerful. Now, when we look at treatments like semaglutide, it appears that when you have a molecule that can effectively penetrate the subcortical areas of the brain and really penetrate those tissues, then you have a treatment that is highly effective also for the disease of obesity. And that's an important concept because many of our diabetology colleagues will know that if we treat diseases of the subcortical areas of the brain, the hypothalamus, the pituitary, etc., these are difficult diseases to treat. And we are now thinking of obesity as a neurological disease, a neuroendocrine disease of the subcortical areas of the brain. And therefore, it makes sense to us that if we are able to penetrate the GLP-1 receptors that sits in the area postrema or the nucleus tractus solitarius or the hypothalamus, if we have those agents, then those agents are going to be more effective than other GLP-1 analogs that, for example, don't penetrate those areas. So I think understanding the anatomy, understanding the organ of interest when it comes to the disease of obesity helps us understand why we see the responses that we do.
Thank you. Thank you. Well, now we have this new kid on the block, tirzepatide. Interested in your comments, again, kind of reviewing the benefits that we're seeing in diabetes and in those without diabetes, and perhaps some comments on why you think people with diabetes typically don't lose as much weight as patients who don't have diabetes with the same treatments.
Carel, that is $1 million question, and I have been, asking the smartest people in the world, and we all have our little pet theories, but I think there's no consensus. It's a really important question that we need to address, which is why is it that people with type 2 diabetes with the same therapy lose less weight than patients that don't have diabetes? Now, interesting, I think some of the insight is going to come when we treat more people with type 1 diabetes and obesity. Of course, there's an epidemic also of obesity in people with type 1 diabetes. And now when we're using these same agents, not from a glycemic point of view, but from a weight loss point of view in type 1 diabetes, the very early data would suggest that the type 1s lose the same amount of weight that people that don't have diabetes. So that's really interesting. So there's something in people with type 2 diabetes that's different to type 1 diabetes or people that don't have diabetes. So I think we need to address this. We don't have a good answer, but let's look at tirzepatide. Amazing drug, 22% weight loss in people without type 2 diabetes, but only 12% weight loss on average with people with type 2 diabetes. So it will tell us that there'll be people who will respond to these drugs, but we will have more non-responders in people with type 2 diabetes when we use these very powerful new, third generation anti-obesity treatments. And I would just say at this point that if you do treat a patient, with a great new drug and they don't respond, it's not because you're a bad doctor or it's a bad drug or it's a bad patient. It really just is that the biology of the disease is not the right biology to be responding to that intervention. So don't despair. There's other treatments as well. And feel free to, use other interventions like nutritional therapies or even bariatric surgery, which remains a very good treatment for our patients.
I think you bring up a really good point. And in fact, if you look at the data with the weight non-responders to GLP-1, it's probably as much as 15%. However, looking at the waterfall plots at the presentation of at least the obesity study for tirzepatide, those numbers were more like 5%. Now, not everybody lost 15, 20%. There were a few that just lost 5%, et cetera. So it appears for some reason that tirzepatide seems to have a greater chance of helping people lose weight compared to even the best GLP-1.
You're correct, but we see that same pattern. It's a sort of a Gaussian distribution, of weight loss. We see that same pattern with nutritional therapies. We see the same pattern with bariatric surgery. All that happens is that the median is just shifted. And, with a very effective treatment like tirzepatide, that has certainly shifted to the right, so more median weight loss, and fewer patients that don't respond have less than 5% weight loss. But we will still have those patients. And I think once we've got over the euphoria of these wonderful new treatments that we have, and it truly is a deserved euphoria, we also need to pay attention to those patients that don't respond, because we see that people with type 2 diabetes, especially people with obesity, suffer a lot of stigma. And you can imagine, how stigmatized you will be if you take a great drug, from a great doctor, you don't respond, because unfortunately, we as doctors, the first thing we do is we very often blame our patients. And we need to be careful with that. So there will be non-responders. Fortunately, there will be few and far between. But if that happens, we need to support those patients and also to manage and work out that there'll be alternatives. And the pipelines are rich when it comes to the companies bringing new treatments forward. So I think we will find treatments that's going to help our patients. Maybe they're 4 years, 5 years away, but I'm very confident that we will find more treatments for our patients.
I recognize that we don't have a lot of evidence in terms of clinical trial use of combinations of medications with GLP-1s or dual agonists. Do you have experience in the clinic in using other anti-obesity medicines on top? And what is your experience with that?
Again, I think type 2 diabetes is a wonderful example, and we don't have to reinvent the wheel, that we can use different classes of medication to attack the disease from different angles. Hypertension is another great example. And what we are seeing is when we are combining treatments, that very often the effects are amplified. I think some of the best evidence building at the moment is patients who have had type 2 diabetes, who had bariatric surgery, who may have had a good response initially, but they then may have had some weight regain or relapse of the type 2 diabetes. And when we add these therapies, for example, GLP-1s or combinations of GLP-1 GIPs, to patients after bariatric surgery, they appear to respond in the same way as they would have responded pre-surgery. So it means that we will end up with more combination therapies, be it combinations between drug classes or even combination between surgical treatments and medications.
I think I'm hearing you say that, yes, you will look at the patient and treat them with safe combinations that you think might be effective at helping them reach their goals.
You're correct, but also it's incumbent on us also to do the science, because it's not good enough for me to go back into my little clinic and come up with all types of concoctions. We need to, test these prospectively. And we also need to support, the industry to do these studies. Even if we think about, combination studies, in people with type 2 diabetes of GLP-1s and SGLT2s, those quality studies, are still lacking. And I know some of them are underway, but there's an example where we have actually things have crept into our guidelines without very robust evidence. Now, I think that's the right thing to do, but we really need to provide the evidence to support that clinical practice.
Well, that's wonderful. Any last comments that you would like to make before we close up today?
I think the future is incredibly bright, for us as clinicians to be able to treat the disease of type 2 diabetes, but also for patients living with type 2 diabetes. I think we will be able to drive down their metabolic complications. I also think that we'll be able to improve their mechanical complications. And I specifically think that the quality of life around the functional domains are going to improve dramatically. So it's going to be a pleasure to work in those clinics, help patients with highly effective treatment options.
I can't agree with you more. Well, Dr. Roux, it's been a true pleasure talking with you about this very important subject. So today we've talked about the importance of monitoring weight and treating weight for our patients with diabetes, not only to improve their glycemic control, but to help to improve their complications, their comorbidities, as well as their quality of life. I want to thank the audience for joining us. This is Dr. Carel Wysham with In Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carel Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.